Please go ahead. Yeah.
Good morning, everyone. Today I am going to present my paper on changes in corneal parameters and tear films after botulinum toxin A in patients with facial dystonia. There is no financial interest. To start with, facial dystonias are movement disorders with repeated involuntary facial muscle contractions, which include essential blepharospasm, hemifacial spasm, apraxia of eyelid opening, Meads syndrome. All these result in undue pressure on the eyelids, adversely interfering with the activities of daily life. Various treatment options are available, but because botulinum toxin is still considered the gold standard treatment because of its efficacy and safety. After internalizing, it loses its light chain to attach to the snare group of protein, and it inactivates it and thus prevents the release of acetylcholine. With application of botulinum toxin, eyelid pressure is released and its effect on corneal morphology, especially astigmatism and tear film, has been noted. But these studies have been done in Western countries and they are of short duration of period. So ethnic differences are also observed in eyelid anatomy, tension and meibomian gland morphology, resulting in dry eye disease. So the aim of the study is to assess the changes in corneal morphology and tear film during the course of action of botulinum toxin A injection in patients with facial dystonia in Central India. It is a prospective, consecutive, observational clinic-based study from October 2016 till May 18, done in Sadguru Netra Chikitsaraya, Chitrakoot, in which 33 eyes of 21 patients suffering from facial dystonias were included. All patients with allergies, previous treatment, corneal surface altering diseases, systemic diseases, and drugs which interfered with neuromuscular transmissions were excluded from the study. After history, ocular examination, systemic examination was done. Severity of spasm was assessed with Jankovic severity grading. Oculus pentacam was used to evaluate the corneal parameters, pachymetric measurements, corneal volume measurements, and finally tear breakup time and Schirmer's test with topical anesthesia was done. Later, measured units of botulinum toxin A injections were given at predetermined sites, and then the patients were followed up after 1 month, 3 months, and 6 months respectively. Statistical analysis was done using a student pair t-test, and p-value less than 0.05 was considered significant. Coming to result, maximum number of patients were in 40 to 60 years of age group with a male preponderance. 11 patients of blepharospasm, 9 of hemifacial spasm, and 2 of apraxia of eyelid opening were included in the study. The spasm severity score showed a significant improvement from baseline to 6 months of period. There was no significance in spherical equivalent. Corneal power improvement was seen from baseline to 6 months period with maximum improvement at 3 months duration. Similarly, astigmatism was also significant from baseline till 6 months post injection, with a shift from astigmatism from with the rule to against the rule. Schirmer's was decreased in the study from baseline to 6 months. Maximum dip was seen at 1 month duration, and tear breakup time increased in the study from baseline to 6 months, but it was not significant. Pachymetric measurements, volume and AC depth were not significant. Coming to discussion, because botulinum toxin has a temporary effect, it is still used as the most common treatment because of its efficacy and safety. In this study, facial dystonia improved after botulinum toxin A from pre-treatment to 6 months period. A few patients, however, showed recurrence after 3 months, which was statistically insignificant. Corneal astigmatism in patients with facial dystonia occur due to undue tension of eyelids on the cornea. This results in flattening of the periphery of the cornea in the superior vertical meridian and conversely steepening in the corneal center. A study done by Suat et al. Showed that congenital ptosis had an increased incidence of astigmatism with a bow tie pattern of corneal topography. Similarly, Levy et al. Also showed that after implanting gold weights for management of leg ophthalmos, they showed pressured astigmatism, and its removal corrected the visual problems. Moon et al. Showed that there was a shift in astigmatism from with to against the rule after injection of botulinum toxin A in patients with blepharospasm. This study also shows a decrease in corneal astigmatism after 1, 3, and 6 months with an against the rule shift. Schirmer's value significantly decreased in the study till 6 months. This is probably because of the increased evaporation of tears due to paralysis of orbicularis oculi, causing reduced blinking after application. Also, secondary reason is as the age increases, there is decrease in production of the tears. And thirdly, the pharmacological effect of botulinum toxin on lacrimal gland results on decreased production of tears by its effect on autonomic nervous system. Tear breakup time increased post-treatment but was statistically insignificant. This is because of the paralytic effect of lacrimal pump mechanism, which outweighs the inhibitory action of mebum production and secretion after botulinum toxin and prevents the drainage of tears and improves the availability on the ocular surface. In this present study, TBUT increased, which was not significant, and Ho et al. Had showed a decrease in TBUT and they had injection in the lateral canthi. Park et al. And Gwens et al. Also showed significant improvement in TBUT after 2 and 3 weeks. So to conclude, botulinum toxin has an effect on corneal astigmatism and tear film with no definite changes in other corneal parameters in the duration of course of its action.